37,000 hospital room visits a year in the US are due to nail gun injuries. Less than 1% of this number is PBIs, penetrating brain injuries. And of this minuscule number, more than 40% are fatal, which makes sense given the critical neurovasculature located within the head and neck region. Now, although this type of injury has been exponentially increasing in prevalence since the invention of the nail gun, it's overall pretty rare injury, and this rarity presents a distinct dilemma for neurosurgeons who may have never encountered this type of injury before. So allow me to paint you a picture of a recent patient that displayed this type of injury. So a 28-year-old black male from a family of West African immigrants with no previous history of psychiatric disturbance presents to the ED with a bilateral nail gun injury after toxic ingestion of rat poison. The patient displayed some mild right-sided weakness and slurred speech, but overall he was alert, responsive, and cooperative. So this patient, again, was alert and responsive, but this injury was intentional and he was attempting suicide, which is commonly seen in patients with this type of injury. So in treatment of this injury, you need to image to assess for vascular risk. So a CT was conducted, and across 30 reports reviewed for this manuscript, CT with or without angiography was the primary imaging modality. The next thing you need to do is remove the foreign body, and that's where the craniotomy comes in, which is virtually standard of care. So a portion of the skull was removed, and the foreign body was removed. The wound was debrided, and all of this was conducted under general anesthesia. The third thing you have to do is monitor for the post-operative outcomes, which are usually infection, pseudoaneurysm, or bleeding. But this patient uniquely exhibited intracranial pressures typically seen in comatose patients who have mass-occupying brain lesions. And this led to unnecessary CSF drainage while the patient was alert, moving, and talking. So the drain was removed, and 26 days post-operative, the patient was discharged to the psych unit, where he, for the first time, received a psychiatric diagnosis of major depressive disorder and schizoaffective disorder. And that brings me to point 4. When it comes to this type of injury, collaboration between the psych unit is needed because the typical demographic are males who have psychiatric disturbances. And diagnosis and treatment, as seen in this patient, could really benefit the underlying cause of the injury. Thank you.